Welcome, everyone. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has a music from here, our guest speaker today. If you have any questions for our guest speaker, you may use a chat feature located at the bottom of the screen. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you if it's complete. Your feedback is important to us as we plan future programs. All right, so it's my pleasure to introduce you all to Angela Reddington. Angela is the Comprehensive Stroke Center Stroke Coordinator for the Department of Neurology at Massachusetts General Hospital. She has worked as a neuroscience nurse at Mass General for 18 years. She has experience in both the General Neurosciences Unit at Lunder 8 and the Neuroscience Intensive Care Unit at Lunder 6. As a stroke coordinator at Mass General, Angela ensures safe, timely, and efficient stroke care by collaborating with multidisciplinary teams to implement best practices and maintain high-quality patient outcomes. In recognition of World Stroke Day, which is tomorrow, she joins us today to give a talk on stroke prevention. So please join me in welcoming Angela.
Thank you. Hi, everyone. Let's get started here. Let me just share my screen. All right. How are we looking? Good? Good. Well, thanks for the introduction. I'd like to just quick add that luckily I was able to do this presentation at home. However, it was just bad timing. I don't have daycare today for my children, so you might hear some noises in the background. Just want to give everyone a heads up, okay? I kind of started to not hear them after a while, so it's fine. Anyways, let's get started about stroke. So I like to show a little statistics right as we first get started. Okay, the big one is every 40 seconds someone has stroke. So this is a very common occurrence today. Over 100 million people worldwide have strokes every year. We actually used to be the third cause of death. All right, it used to be the top 3 killer of Americans. However, we have dropped to the 5th, which is because we have new stroke technology out there that now has been able to save lives. And that's why we've had a real big push of stroke education in the media and in the public, is because now we have ways to actually treat your stroke, some types of strokes that you have. And so we have dropped. We also, which I'll comment more about in the next couple minutes, that women have a couple more, are at risk for more stroke than men. And a lot of times once you have a stroke, you are always at risk for having another stroke. All right, 1 in 4 people that have had strokes have had a previous one. And lastly, the big take home, if you remember anything about this, is that 80% of all strokes can be prevented. All right, this is the most important statistic. 4 out of 5 strokes are preventable. And really, it's dramatically reducing our risk with healthy lifestyle modifications. That's all you need to do. So let's first talk about what a stroke is. We have a stroke is considered a disease that affects the arteries supply in the brain. So that's your main blood flow that goes through your head and supplies your brain with energy, glucose, oxygen, those important things for survival. Sometimes people call this a cerebral vascular accident. And this is what happens is a blood vessel in those cerebral arteries either become blocked or can rupture. 2 different definitions of stroke. We'll get into that. When this happens, that area of the brain is damaged because it no longer is getting that essential nutrition and oxygen, and they start to die, those brain cells. This is considered a medical emergency. And because these brain cells die so quickly, time is critical. Getting immediate treatment can save this brain function and save your life. The faster we get to the hospital, the better chances people have of recovery and less of long-term disability. I'm just going to move on my little picture here. So we actually have two different types of stroke. And the first one I want to talk about is called ischemic stroke. So an ischemic stroke occurs when there's a blood clot that blocks the blood vessel that supplies to the brain. This artery usually becomes narrowed, or a clot comes and that whole area becomes blocked. It's kind of like a clogged pipe. The blood can't get through, so that brain doesn't get that oxygen that it needs to survive. We can actually divide our ischemic stroke into thrombotic and embolic. And just to note, ischemic stroke is the most of the strokes we see. It's about 85% of all the strokes. So this is what we think about when we see patients having a stroke. Oh, I have a question right away. Oh, that was just Amy. Anyways, we can divide ischemic strokes into thrombotic strokes, which is about half of the strokes. So this is also very commonly seen. And this thrombotic strokes, consider it like a type of local blockage, all right? The clot or this blockage forms right in the brain's blood supply, right in the area of the brain here. And a lot of times this occurs because fatty deposits, think about like grease in a pipe, build up on the artery walls. And this buildup is called atherosclerosis, or we can call this as plaque. And this plaque buildup eventually gets so big that it starts to narrow and a clot forms and blocks that blood flow completely. So I actually, just to go forward slightly, made a slide on what atherosclerosis looks like, okay? So as you can see here, a vessel that doesn't have atherosclerosis, you have these blood vessels that are able to flow freely back and forth, all right? So as we develop these fatty plaques, which is what we call atherosclerosis, this buildup becomes, starts to interfere with the flow of the blood that's through our brain. And a lot of times this is from high cholesterol, unhealthy diet, people who smoke, even high blood pressure can increase your risk. Eventually starts to wear away at the vessels. And as we start to build up, you can see this bottom image here. The artery becomes narrower, blood can't flow very easily, and something such as a clot, which is this right here, can easily block this off. And this is what a stroke happens. And this is what happens in your heart, with your heart vessels. Same thing, just different organ. To go back, we also have an embolic stroke. This is like a traveling blockage, all right? And a clot forms somewhere else in your body. Often it's in your heart or in your neck, and then it travels through the bloodstream, and then it gets stuck in your brain and in those arteries of your brain. One of the big causes of this that I like to talk about is atrial fibrillation, which is an irregular heartbeat. And this causes clots to form in your heart. And then when those clots get broken off, they actually go directly into your brain. And that's when they can cause a blockage. So both thrombotic and embolic strokes cut off blood flow to the brain tissue, and both are medical emergencies. So the big point here is to get treatment fast so we can restore flow, hopefully, and save those brain cells. The other type of stroke I want to mention is a hemorrhagic stroke. So a hemorrhagic stroke means there's bleeding in the brain because a blood vessel has broken open. So this kind of stroke happens suddenly, and it's not caused by an accident, injury, fall, car crash, or we would say trauma induced. Okay, this is just all of a sudden this blood vessel bursts in your brain. Why does this happen? Often because of high blood pressure. Not just one high blood pressure, but chronic, right? You've had blood pressure for a very, very long time. It's starting to wear away that inside of your blood vessel, right? Like an old garden hose, and it springs a leak because all of a sudden it just had too much pressure. We sometimes call this type of stroke a brain bleed. So if you've heard that term before, it usually means a hemorrhagic stroke, right? We can also break down hemorrhagic strokes into two other categories. To note, hemorrhagic strokes are usually are less common, but they're more serious. They usually have more associated problems, including loss of consciousness, severe disability, and they actually have higher rates of death. What we kind of are familiar with, many of you may have heard of subarachnoid hemorrhages, and this happens when a patient has an aneurysm often. This occurs when the blood vessel is actually in between the brain and the brain tissue. This causes a very sudden and severe headache all of a sudden out of the blue. A lot of textbooks refer to this as the thunderclap headache. Like all of a sudden you just get this terrible, like thunder hits you, or lightning, I guess, would hit you, type of headache. And this is often when an aneurysm bursts. So this is actually a type of stroke. And an aneurysm, just to clarify, it's usually like a little bubble of a weakness out of the blood vessel, and that pops, right? So you can kind of see a little picture of like how this kind of outpouches. And so a lot of people forget that that's actually a type of stroke. And then we have what's called intracerebral hemorrhage or intraparenchymal hemorrhage, which is just another fancy way to say brain tissues. And this is when we have the bleeding directly onto the brain tissue itself. And again, most likely this is usually due to hypertension. I also kind of want to talk about a little mini stroke. And this is a transient ischemic attack, also called a TIA. So this is a temporary blockage. So part of your brain does not get blood supply for a very short amount of time. So think of that garden hose again, someone just stepping on it for a second and then letting up, right? You're going to often see symptoms of stroke, but they actually resolve within minutes to hours. And so I always want to say this is a big warning sign that, hey, your vessels are not doing well. You're at risk for having a stroke really soon. I think they say 1 in 3 people that have a TIA in the next, I think, a 2-week time period, over 50% of them end up having a full-blown stroke. So it's a critical warning. Don't ignore this. And please, if you ever have these types of symptoms that we'll go over soon, even if it's a TIA, always come in to get checked. The good thing about TIAs is you don't have any permanent neurological effect, and those symptoms usually go away, usually minutes to hours, but they can say up to like 12 or 24 can still be considered a TIA. And a lot of times this is often double or blurry vision that all of a sudden comes unexpectedly. So we talked about what stroke is. What puts you at risk for having a stroke? So we have a couple risk factors that can, or we call them non-modifiable risk factors. Basically, these are things that increase your risk for stroke, and unfortunately, you don't really have any control over them. It just is how you are or how your life history is. So some of these things that we can talk about is age, for example. The risk of stroke is going to increase as we get older. Our blood vessels get older, they're not as pliable, we have atherosclerosis, so something that happens over time, etc. All right. After 55, the chance of having a stroke actually doubles with each decade of life. So we are more at risk, but do remember strokes can still happen at any age, even in young adults, which we've actually seen a lot more of now that we've had better technology about detecting some of these risk factors. Another thing is family risk factors or family history. So a lot of times if you have a close relative, parent, sibling who's had a stroke, your risk can also be higher. And a lot of times they say this is due to maybe shared genetics or even just similar lifestyle factors. You know, a lot of people in the same family have high blood pressure, diabetes, high cholesterol, that sort of thing. When it comes to race and ethnicity, stroke risk does seem to cater to certain groups. African Americans, Hispanic Americans, Native Americans, for example, are about twice as likely to have a stroke and are more likely to die to stroke compared to white Americans. This might be higher rates of high blood pressure, diabetes, and heart disease that already is in that group already. Like I mentioned before, men are most likely to have a stroke at a younger age, but of course, women have a higher risk after menopause, right? Menopause is just the problem of everything. And a lot of times this has to do with hormonal involvement. We also are most likely to die from stroke because we're having these strokes at older ages. So oftentimes women that have stroke, it's more severe of a presentation. And lastly, like I mentioned before, having a prior stroke or having a TIA, this is a big warning sign that a larger stroke could occur. That full risk, that full year after TIA is what they say is your highest risk. And so sometimes I always want to tell people that, you know, when they're in the hospital and they're calling their family and they're all better, they had a stroke, it's fine, they're good now. I want to be like, no, you're not good. This is a sign for you to take care of yourself moving forward, that you're actually more at risk moving forward. So let's go over some stroke risk factors you actually can control. So, stroke risk factors, and these are things that, you know, increase your risk of having a stroke, but we can change these. We can manage these, we can make lifestyle choices, we can do medical treatment, and we have the actual power to, did I miss one? I missed it. Sorry, I'm trying to scroll down on the screen. Apparently I'm scrolling through my slides. Anyways, so we have the power to reduce our stroke risk by making these healthy changes. The big one that is the number one cause of stroke, both hemorrhagic and ischemic actually, is high blood pressure. High blood pressure puts extra strain on your arteries and makes them most likely to burst. They can also wear away the arteries, making them more sticky. So things like clots can stick to them, so make them a higher chance for ischemic stroke. They always say, keep your blood pressure less than 120 and 120 over 80. If you need to take medication, make sure you're taking your medication. We can work on our diet, exercise. This is really one of the most effective ways to prevent your having a stroke, is really keeping your blood pressure under control. Diabetes. So diabetes increases your risk of stroke. It almost doubles your risk of having a stroke. And because, you know, those sugar crystals actually can damage the inside of your blood vessels over time, and that's easier for blood clots to stick to those vessels. It also can make clots easier to form in your body. And so really managing your blood sugar levels and staying active can really reduce this risk. And then cholesterol, right? Too much cholesterol is going to lead to those fat deposits in the arteries we just talked about, the atherosclerosis. All right. And these can narrow vessels all of your body, right? Brain, hearts. You're really at risk for a lot of vascular diseases. So what do we say to try to keep your cholesterol down, either with medications that are prescribed, exercising, a healthy diet, and really try to keep that circulating cholesterol in your body low. Speaking of circulation, if you have conditions that affect your circulation, peripheral artery disease, carotid artery disease, these really increase your risk of clots traveling to the brain. And this is one thing that regular checkups can help prevent before you have, you know, these arteries will start to see a stroke from occurring because you have acknowledged these problems already. And I also like to kind of add in the circulation problem about any type of heart disease. Heart disease is similar to your brain, and any clots that or poor blood flow, this can often relate directly to your brain. So heart disease can actually put you at risk for stroke as well. Speaking of hearts, atrial fibrillation, like I mentioned, this is a irregular heart rhythm, and it causes blood to pool in the right atrium of your heart. When blood pools, it clots. Then these clots can travel directly up to the brain. They say that treating atrial fibrillation with medications or procedures can actually lower your stroke risk as much as 70%. So some of our stroke risk factors slash how we can work on reducing our stroke risk factors that I like to talk about are quitting smoking. Smoking damages your blood vessels. It can actually raise your blood pressure. It can actually thicken your blood. These are all things that put you at risk for stroke. They actually are finding that vaping is also in this category, and it can expose your body to harmful chemicals that can affect your circulation. They say that current smokers have a 2 to 4 times increased risk of stroke compared to non-smokers. However, if you quit smoking, it actually decreases your stroke risk immediately. And within 2 to 5 years, your stroke risk will be the exact same as that as a non-smoker. So it makes a big difference to stop smoking. Another thing is trying to reduce heavy alcohol use. Drinking too much alcohol can raise your blood pressure. It can even lead to irregular heart rhythms. And what they define, the textbook says, heavy drinking is more than 1 drink a day for non-pregnant women or 2 drinks for men per day. Both of these can increase your risk for both ischemic and hemorrhagic stroke. Again, maintain a healthy weight. Having extra weight puts strain on your heart. It puts strain on your blood vessels. This increases your risk for high blood pressure, diabetes, high cholesterol, right? We all just talked about our major stroke risk factors. They say that even a 5 to 10% weight loss makes a big difference in lowering your stroke risk. A 30-minute brisk walk each day, which is 15 minutes each way, right? They always want to say, or even 150 minutes of moderate exercise per week has been shown to really improve health and well-being and decrease your stroke risk. Oh, why does it keep doing that? I apologize. Lastly, eat a healthy diet. So what does healthy mean, right? It's so hard in today's media, what is good, what is bad to eat. So basically, lots of foods that support your heart. Fruits, vegetables, whole grains, lean proteins, healthy fats, limit what? Salt, sugar, and minimally processed foods. They say like a Mediterranean diet has to reduce your stroke risk. All right, so I told you all about strokes that happen, how to prevent these strokes. How do we know when a stroke is actually happening? So you probably have seen this acronym FAST, all right? And we started to really push this education in the media because we're able now to do some stroke treatments that can actually literally save your life, reduce a lot of your chances of having long-term effects from a stroke. The big thing, though, is that we have a time frame. There's a time limit. The clock starts once you notice you have the symptoms of stroke. So we'll get into what those clocks are because now we have a couple. So that's why we're trying to educate the public. If you think you're having a stroke, come to the emergency room as soon as possible. So what are the big things that we're looking for when we are worried about having a stroke? We look at the FAST. F is for face. The big way you can tell is that your face is going to be droopy. How can you tell if it's droopy? Ask the person to smile. Usually you can see one side droops or it'll look uneven. And this is really one of the big first visible ways that you can tell someone's having a stroke. Also, A is for arms. What happens with a stroke? It affects one part of our body, and one side of our body is going to be weaker than the other. The way we can usually tell is by lifting up our arms and seeing if one drops. Oftentimes, patients will tell me that they knew they were having a stroke because they couldn't pick up their coffee, or they went to grab the remote for the TV and couldn't grab it, or they couldn't push the buttons. All of a sudden, something that you think that you can do normally is gone. Do with just that motor control of one side. Often people will have numbness as well. All of a sudden, one arm goes numb. They can't tell what they're grabbing. They're doing the dishes and they realize they can't feel the dishes anymore. You hear all these stories about how one side often becomes very weak. Same thing for speech. This is often how someone else can tell that you're having a stroke. You think you're speaking normally and you're not. All right. All of a sudden, your speech becomes mumbled. They're slurred, thick, and very difficult to understand. And sometimes the person that's having a stroke doesn't realize their speech is coming out strange. And it's somebody else that says, "You're talking funny. What's wrong with you?" And so sometimes it's like, "Can you repeat something?" We always say, "The sky is blue." And see how that sounds, how that patient's able to speak. And a lot of times it's because one side of their face is droopy. And that's when you're like, "Wait, can you smile?" So that goes kind of hand in hand that you're having a stroke. Then the last letter, T, is for time. Time is critical. You notice any of these things happen, please call 911. One of the big things I always tell people is call 911 and have EMS pick you up. Please do not get in your car and sit on 93 for 4 hours. Okay, by then you lost it. There's no time to fix you. We have a window of treatment. You're out of that window. We can't do anything for you. All right. We have EMS. They can recognize a stroke. They can call ahead nowadays. They can clear the table for you to get a scan. We have lots of great resources and lots of great processes in place now for people who are having stroke, all because it's so important that you come to the emergency room as soon as you possibly can. So please call 911. Please call EMS. Do not get in your car. I hear so many sad stories about that. I mean, it took me an hour and a half to go to a Bruins game the other week, and I live 20 miles away. So you never know what you're going to get in Boston traffic, right? So now I'm going to throw a little wrench at you, right? I just told you all about FAST, but now I'm going to show you something a little bit more fancy. Okay. So yes, the original acronym for FAST, face, arm, speech, times, works, but we found out that we were sort of missing some people that were having strokes. So the big experts added something. We made FAST into Be Fast, and we added B and E to help catch more strokes because we were missing people that were having problems with their balance or their vision. So B is for balance. And so this is when a person all of a sudden has trouble walking, immediate dizziness, they feel the room is spinning, they often get nauseous because it's so terrible that they can't even find their equilibrium. They can't coordinate their arms and legs. This is a sign that you could be having a stroke. And oftentimes this was missed. People didn't know that having dizziness and problems with balance could be a stroke, right? It didn't fit in the FAST. Same thing for E. E is for eyes. Has the person all of a sudden suddenly lost vision in one or both eyes? Are you seeing double? Is it blurry? This is all sudden changes. And people would have this and go make an appointment with their ophthalmologist in 2 or 3 days and not realize that they were having a stroke. So again, we add this B and E to detect strokes. And why? These strokes occur in the back of the brain, the cerebellum and the brainstem. And so this was being missed. And so now I really push for people to think of Be Fast when it comes to stroke symptoms. And remember, these are all very sudden signs of stroke. And let me show you how quickly this can happen. I have a video which keeps on telling me that I'm a bot. I'm going to see by chance if it's going to work. No. But I can open it in a browser. This is a little bit intense video, but I want you to see how fast this can happen.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I just
Honey?
Dad!
Tim!
need an ambulance to Seven Fuller
Tim! Tim, look at me, Gracie. Tell them to hurry. Tim, look at me. Look at me, Tim.
Mom, what do I tell
Dad, I don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband, he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. I'm right here. Gracie, meet us there. I'm right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim?
Dad? Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
So that was a little intense, but a good segue into how we can treat stroke, right? Things happen that fast. People that I've taken care of will tell me, no, they were at Thanksgiving dinner, they were eating, and all of a sudden they slumped over in the chair. Or they were literally having coffee in the morning, went to grab the coffee cup and it dropped out of their hand. That happens really quick. And so that's why it's really important to be aware that what's happening is a medical emergency and to get treatment. So let's talk about treatment. First, again, just going to push this even more, is how important it is to get to the emergency room as fast as you can if you think you're having a stroke. And we call it the time is brain. Okay. When you have a stroke, these brain cells die and they can't grow back. And this is why getting this treatment is so critical. And here's some stats that are a little alarming. Every minute without treatment, the brain loses about 2 million brain cells. Every hour without treatment, the brain ages as much as it normally would in almost 4 years. So think how much aging you add if you go to sleep at night, not feeling well. That whole night, you could have gotten treated. And so we always say time is brain, and it means the faster you get to treatment, the more brain cells we can save. Every minute that there's a delay, more permanent brain damage can occur. So this is why we always say to call 911. Don't drive yourself, please. Is because we now have all these treatments that can actually help. So let's talk about them so you kind of know what's out there. First of all, we have treatments for ischemic stroke. So remember, ischemic stroke is about 85% of the strokes that come in. So there's a good chance if you do have a stroke, it's going to be ischemic. And there's some things that we can do to either get you back to yourself 100% or close to it. And the first thing is we can give you what's called a thrombolytic medication. There's 2 different kinds that are out there that you may hear: alteplase, which is called TPA, or tenecteplase, which we call TNK. So this medication is given through an IV in your arm. It's not an infusion. The alteplase is a little bit of infusion, and the TNK, you can just push it in pretty quick. What does this do? It breaks down the clot in your brain, and it's going to improve blood flow to that part of the brain that's affected. So, the big thing to remember is that we have a small window for this treatment. You have to arrive to the hospital within 4.5 hours of when the stroke symptoms started. So, like I said, you have these stroke symptoms, you drive yourself down to, the Boston hospital, and it's, there's a huge accident in 93, you might fall into this window. Also, we need to make sure that we scan your head when you come to the emergency room. So we can get a CT scan, which we'll talk about, to determine what kind of stroke you're having. Are you having ischemic? Are you having hemorrhagic? If you're having an ischemic and it's been within 4.5 hours, we can give you a thrombolytic. And oftentimes they'll give it to you in the CT scanner. They don't mess around with time, which is great, right? Next, we have a treatment called a thrombectomy. So a thrombectomy just basically means removing a clot. And you can also have thrombectomies in other areas of your body. This thrombectomy is removing a clot from your brain. Yes, this is some brain surgery. Surgeons actually go into the artery, femoral artery of your vein, of your groin, and they thread a catheter all the way up into your head, and they can actually pull out that blood clot that's blocking that blood vessel in your brain. So it's like using a little grabber or vacuum cleaner to capture the clot, and they kind of fish it out. So this procedure is for ischemic stroke patients And it's also if the clot is located in the larger arteries of the brain, because those clots are easier to find and fish out. If you have smaller clots, a lot of times we can't do a thrombectomy, but we can do thrombolytics. Again, if you get to the emergency room in a certain amount of time, right? That 4.5-hour window. And there's also some other eligibility. Not everyone qualifies, but they're going to determine when you get in here, when you get to the emergency room, if this is a procedure that you're a good candidate for. We have a time window as well for thrombectomies. The good part, it's a bigger time frame. We really like to do thrombectomies within 6 hours of when your stroke symptoms started, but we can do it up to 24 hours if the brain scans don't show that the brain tissue has been permanently damaged yet. And we have very fancy scans nowadays that can do that very quickly. And, you know, for certain types of strokes, especially these big vessel, cerebral like arteries in your brain, this is really effective. And it's more effective than thrombolytics. So, you know, one treatment's dissolving the clot and this one's actually taking it and removing it, right? So one may work a little bit better. As they say, this is the most direct approach, which can immediately save brain tissue. I have a little 1-minute video that exactly shows you how they do it. Also, let's see if this one works in the browser since it says.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
Yeah, so that's literally, sometimes it's less than an hour. It's so quick. And again, though, this is major brain surgery. Doesn't look like it. It seems very less invasive, but there are risks of surgery. So if you, a lot of times, if your symptoms aren't too bad, I know that's a hard thing to say, right? Sometimes this won't be an option for you because the risks of surgery outweigh the benefits of doing rehabilitation or having a thrombolytic. But it's so cool what they can do nowadays. So this is one of my favorite pictures. This is what actual blood clots in your brain look like. So these are what can kill you. These small, tiny little blood clots that they've pulled from people's brains have actually obstructed entire parts of people's brains. So anyways, I'd like to see that to show how small these little clots are. So I'm just gonna go over quick, if you do have a stroke, what happens or what to expect during this process. What I first want to really mention, because many of us are probably listening from, you know, all over Massachusetts, we're not in the city by all these big hospitals, that there's a couple different types of stroke levels of care. And we've kind of probably heard about this with trauma. Trauma centers have different levels of capacity, and stroke centers are the same way. We have certifications based on what treatments are available at that hospital. So think of it like a basic clinic versus going to a specialized hospital. Each level can handle more complex cases. So we have about 4 levels, and they all relate to each other because if they're unable to handle a patient, they can transfer to the next and next and next. Really quickly, we have an acute stroke ready hospital, which if you think you're having stroke symptoms, you can present to the emergency room, they can scan you, they can assess the stroke, and they can give you IV thrombolysis, so that TNK, or they can give you the tenecteplase or the alteplase, excuse me. And a lot of times, though, that's all they can do. If you need more stroke care, they're going to have to send you somewhere else because they don't have the capability to take care of you, but they can at least identify and treat you. Next, we have a primary stroke center. And this is the same as acute ready stroke. You can come in, get scanned, you can get thrombolytic therapy. And these hospitals often are able to take care of you if you have a very minimal stroke or you don't have any complications. They are able to have a stroke capacity for beds there. Then we actually have thrombectomy capable stroke centers, which is a newer level. Same thing as the primary care, but these hospitals do have operating room suites that can do a thrombectomy. So you can actually get a thrombectomy. And for the most part, a lot of these patients will stay at this hospital, but if there are complications, they have to go to a comprehensive stroke center. This is the highest tier of stroke care. A comprehensive stroke care is able to do all the things that the thrombectomy, primary, and acute can do. And they're also able to care for any type of stroke patient, any type of patient after therapy. They often have a neurological intensive care unit specific for these types of patients. They can take all hemorrhagic strokes. They have neurocritical care that are able to care for you. They have rehabilitation services, an interdisciplinary plan of care to help you with PT, OT, that sort of thing. It's the top of the line, right? What is Mass General? A comprehensive stroke center. Okay. Also, because we live in Boston, we're so lucky because Brigham and Women's Hospital is a comprehensive stroke center, Boston Medical Center, Beth Israel Deaconess Medical Center, and actually UMass Memorial Medical Center just recently got certified. So a lot of these smaller outside hospitals are going to give you great stroke care. So if you're having stroke symptoms, don't drive all the way to Boston for stroke care. Go to a small hospital. First of all, you shouldn't be driving, but EMS will know to bring you to one of these centers to give you the best care. And then often these small hospitals have contracts with these comprehensive stroke centers. If they do receive a very complicated hemorrhagic stroke, or there's a very sick patient that got thrombolytics, we all have contracts to get these patients. So my takeaway from this slide is that don't panic if you're going to a small community hospital. Oftentimes, they're really good at stroke care. They're going to get you to a scanner fast. They're going to realize you're having a stroke, and they're going to get you treatment. And then if you have to be transferred, they have that all set up. So oftentimes people worry here like, oh, I have to go to a big hospital. I'm having a stroke. You don't. You get really great stroke care, really fast care at these smaller hospitals. And oftentimes that's where EMS will bring you. Okay. If they think, and EMS is currently being trained on this, that you are having a stroke in one of those larger vessels in your brain and you are more a candidate for a thrombectomy, sometimes they will bring you to a comprehensive stroke center. But to be honest, they're going to bring you to the closest acute stroke ready or primary stroke ready that they can so that you can get scanned and get a thrombolytic if you qualify for it as soon as you can, right? Because it's a 4.5 hour window, it's small. So I really just always want to say, don't feel like you need to come to these big hospitals. Your community and your these acute ready and primary stroke hospitals do really well and can get you treated very quickly, which is the whole point. Let's really quick just go over what to expect if you are hospitalized and found to have a stroke. We're going to really closely monitor you. We're really actually going to monitor you so closely, it's going to be annoying. And I always try to warn my patients about this. Question in the chat. Is there a way to know which hospitals offer stroke centers? They usually have it announced somewhere on their website because getting a stroke certification is something to kind of brag about. So it should be somewhere if you do a quick Google search. And like I said, the EMS are actually currently getting educated about which hospitals to bring stroke patients. So they're learning how to get the best stroke care. But yeah, if you Google also like stroke centers of care, they usually will pop up right away because they do get like a special certification and it's usually documented somewhere. So good question. All right, back to getting annoyed in the hospital. All right, what do I mean by being annoyed? We're going to be doing these very frequent neurological assessments. We're going to be regularly checking your brain function to making sure there's no changes. We're going to ask you, what's your name? Where are you? Can you tell me what happened? What year is it? We're also going to make you squeeze our hands, push and pull. We're going to put a flashlight in your pupils. And these are all just to check to make sure that there's no complications from you having a stroke. This could be swelling or bleeding, and that happens kind of suddenly. So this is why we're doing this very often. We're also going to be checking your blood pressure, temperature, heart rate. You're probably going to have to wear a cardiac heart monitor on for at least the first 24 hours because sometimes people have strokes because they have an unknown irregular heart rhythm, and we catch it when we put a heart monitor on for that first 24 hours. And then we realize, oh, they're going in and out of atrial fibrillation. That's probably why they have this stroke. But sometimes you can't tell. So that's how a lot of times people find out that they had that rhythm. Also, have an expectation of being poked with a needle a lot. We're going to be doing a lot of blood work, looking at things like your electrolytes, which are your minerals. And we're going to be looking at certain types of tests to see how well your blood clots. Some people have clotting disorders and their body is making clots faster than the average person, and this is why they end up having a stroke. We're going to be checking your red blood cells, white blood cells, and a bunch of other blood works to see your stroke risk. We'll look at cholesterol levels, that type of thing as well. We're going to do a lot of pictures of your head. All right. You need to have a scan of your head when you first present to the emergency room. And that is to see if you have an ischemic stroke or a hemorrhagic stroke, because your treatments are different. So if you have a bleed in your head, we will not be giving you thrombolytics. We will not be giving you a thrombectomy. That is we usually just medically treat you. And if you do have, if we think you're at risk for an ischemic stroke, we can do more treatment. A lot of times we'll be getting an MRI, which is our more detailed magnetic pictures to see how the vessels in your brain look, what's going on with areas that are damaged. That's what we can see on an MRI. The CTs are more quick pictures. A lot of times we'll look at ultrasounds, and this is just looking at imaging of blood vessels in your brain and your neck. A lot of times we'll do neck ones, look at your carotid, because oftentimes your carotid is what gets full of atherosclerosis and can get blocked. And you're going to be seeing a lot of people. All right. You're going to be seeing doctors, physical therapists, occupational therapists, speech therapists, case management, social work, chaplaincy if you want, which is a nice part about these, the comprehensive stroke centers is because we have this full team, and even a lot of the primary and acute ready will have this team to help you with your stroke care. All right. And also make sure that you're getting proper help and rehabilitation after, okay, your discharge. Let's go. There it goes. All right. During your hospital, you might be started on new medication to help your blood pressure. You might have medication to help with your cholesterol level and reduce that fatty buildup. They might put you on an anticoagulant, or what we call blood thinner, which prevents new clots from forming. You might get put on aspirin, which helps prevent blood clots and also can reduce your stroke risk, and other medications on your needs. We're going to get you out of bed a lot. We want you moving. We want that brain working, okay? We like to try to get these patients, we want to make sure you're up in a chair. Even if you're having weakness on one side of the body, we're still going to get that blood flow and those muscles working so they don't atrophy. What do you think? Staying in the hospital? It all depends, right? Depends on what other things are going on with your stroke, what other issues you may have, if you got treatment, if you didn't get treatment. I would say 1 day to a week. All right. Sometimes people come in and get treated with a thrombolytic, thrombectomy, and they can almost go home the next day because they're almost back to normal. It's really great what they can do with that treatment if you can get there, right? If you can get there in a short amount of time. And like I said, we're going to help you with any types of services you need, when you're going home, or if you're going to rehabilitation, or even if things take a turn for the worse and we're going to help you with palliative care, which is comfort focused care if we're not going to be making a recovery. We also will do a lot of education with you. We're going to go over the stroke you had. We're going to go over your risk factors. We're going to go over how to prevent another stroke and go over all the medications you're starting while you're in the hospital. And even outpatient, when you see have your follow-up appointment, they'll also go over this again as well. Because sometimes you got a lot going on in your head when you have a stroke. It's hard to really absorb everything that's coming at you. So there's a lot of repeat education that occurs. So lastly, how do you recover from a stroke? And I like to kind of end on this because this is how people can recover. And it's basically our brain's pretty awesome. It can retrain itself to take over lost functions. All right. It's something called neuroplasticity. So it's this really remarkable ability that the brain can reorganize. It can rewire itself. And I like to think of it as like, it's a brain city. Your brain is like a city with roads. So if one road is damaged and you can't use it anymore, it's a dead end, the city can build a new route around it to get traffic flowing again. That's what happens in your brain. All right. This can help you with your speech, movement, vision, hearing. It just forms these new connections to regain those lost abilities. This neuroplasticity actually starts just days after having your stroke. Your body starts to learn to recover. And it also helps you this is also why we really push for you to go to rehab, because this is what's going to keep that blood moving in your brain and helps your brain learn those new skills and recover faster. So a lot of times people feel like, oh, you're like kicking me out of the hospital, like kicking me out to rehab. Yes, we absolutely are kicking you out to rehab. We need you moving. We want you to start making this neuroplasticity process as soon as you can. All right, learning new skills. You need to recover faster. The more you practice, the more of those connections and stronger those connections happen. If you don't challenge the brain, those abilities can weaken over time. All right, so this is why we really push that therapy and continued practice. And oh, my last slide, I had copied over and forgot to remove it. That's it for me. If anyone has any other questions, please throw it in the chat and let me know.
Thank you, Angela. This was helpful. We're now at the end of the session. If you have any questions for Angela, feel free to enter them in the chat. We have a question regarding if there's any new research or any new treatments on the horizon for stroke recovery and treatment.
There's always. The most pertinent one that I think is the most exciting is that they're really hoping to give that thrombolytic outside that 4.5-hour window. So the big push now, and they have a lot of research on it, is to give a thrombolytic in the first 24 hours and see if that can help with patients' recovery, is to push for that earlier that bigger window for the thrombolytics. So that's the big one that I know about.
Thank you. Earlier in your slide, you showed a image of a person who depicts as a man. Is there any particular reason why an image of a man is used? Because
So
that could give like the impression that, you know, it tends to affect men more than women.
Well, it does affect men more than women until women get to menopause. So that that age of young men to, you know, men in like, you know, the 40s, 50s, 60s. And then once women have menopause, we take over the risk. So I do think that there is that a little biased picture of men having strokes, because we do usually see more strokes in men in that younger age. So, but like, again, you know, now that we've had more, we actually have been seeing a lot more younger women. We've been seeing a lot more pregnant women having strokes, postpartum women, and healthy young people in general. So, but yeah, there's a lot of picture of men, but technically right now you're still at the highest risk.
Is there any reason why you're seeing it more among pregnant women, postpartum women?
Well, I think mostly now it's just really identified, you know, preeclampsia when the woman has high blood pressure associated with pregnancy. They're finding that postpartum, that 2-week period postpartum, women are really at risk still for preeclampsia, where before we kind of thought, oh, you had the baby, you're fine. And then this 2-week postpartum window, we found more people, they're having hemorrhagic strokes, right? Because high blood pressure is hemorrhagic strokes. And they found that that 2-week postpartum is still they had still high blood pressure then. And so they were finding that a lot of women were having hemorrhagic strokes because of it. So now they're really focusing on, if you had high blood pressure during your pregnancy, here's a blood pressure cuff, go home and check it after the baby. You're not safe yet. There's still a chance that things could happen to you now that you've had the baby. Your blood pressure is still high. And oftentimes they're on medications and they can stop it, much later. But yeah, that has been a new focus, that there's been a lot more of the postpartum strokes specifically.
Thank you.
Mhm.
We have a question regarding baby aspirin. What are your thoughts on daily baby aspirin for stroke prevention?
So aspirin, a lot of people think of aspirin as it's a pain. It is working. It's actually considered a non-steroidal anti-inflammatory drug. It's an NSAID. But what it does is it helps with decreasing platelet aggravation. What does that fancy word mean? It basically means when we have an injury, we cut ourselves, our platelets come to that clot and they clump up to try to stop the bleeding. So that's how our platelets work in our body. However, when they clump up, after about 48 hours, they can fall off, and often they stay as a clump. What does that clump look like? A clot. So how are people sometimes having strokes? From their own platelet clumps, right? Because if you have the atherosclerosis and your vessels are really small, anything can clog that up, including a platelet clump. So having a small dose of aspirin is going to decrease the body's ability to really clump the platelets together. They're still going to work, right? You're not going to bleed out and die because you're on aspirin. It's still going to clump and try to prevent that bleeding from happening, but it's just not going to keep them into that big aggravated form as much. And so it just lowers your stroke risk overall. So I think it's important. Yeah, I think it do, especially if you're at risk for stroke. Having a baby aspirin, I think, really does help with your stroke risk, just because it's not going to let your body clump up those platelets, which can eventually lead to a blockage somewhere in your body.
And would you say this is recommended for everyone or only if you're at increased risk for stroke?
It's only if you're increased risk for stroke. But I mean, that's like a very broad statement, right? Like, for example, my husband, who's, in his 40s like me, young, healthy guy, but his father passed away suddenly from a heart attack. So his cardiologist wanted him on a baby aspirin just because he has a family history, even though he's a healthy, exercises man. So, the window of what you think a stroke risk is really, it's big. So it all depends on what your family history is, what your doctor thinks, what your, any of those types of things can affect if aspirin would be appropriate for you or not. I'm not on aspirin. I don't have that same risk. So that's a big provider specific question, I guess. But yeah, does that help answer, I guess?
Yes. So in the end, always consult with your doctor before starting on it.
Right. Because you don't know, a lot of it is very specific to you,
Sure.
your family history, are you already having hypertension? Are you diabetes? Are you already having a couple of those stroke risk factors? So that itself too could be important for you to be on aspirin or not be on aspirin.
Thank you.
Mhm.
And do you have any online resources that you would recommend one to visit to learn more about stroke?
Yes, my favorite go-to is the American Heart Association or the American Stroke Association. Their website's awesome when it comes to having a lot of stroke resources, stroke information. The MassGov for stroke also has a big website. They have like free fast like magnets you can get or like flyers. They have some really good information as well. Those are my two usual go-tos when it comes to stroke education.
Wonderful. Thank you. So we are at time. Before we end today's session, Angela, do you have any final thoughts you'd like to share with the audience?
Well, thank you for taking the time to listen about stroke. I'm very passionate about it, and it's really great to spread education, because the more education we have, I think the safer we can be. Also, not just for yourselves, but for loved ones that are experiencing this that don't know what's going on. So I just really thank everyone and their time for learning about stroke.
Absolutely. Thank you so much, Angela. This was extremely helpful.
Thanks.
And for everyone joining us today, thank you so much. As I had mentioned, today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website. And I'll just enter that in the chat for everyone. That's massgeneral.org/Blum-Center. Thank you so much, everyone. Take care.
Thank you.